Good afternoon or good morning, everyone, and thank you all so much for joining us today. My name is Andrew Zaffel, and I'm the Manager for Health Equity at NASTAD. We're going to start the webinar in just a few moments. We're going to give a few more people some time to join us, so please sit tight and we'll get started in just a few more minutes. Thank you all so much. All right, we're going to go ahead and get started. Thank you all again so much for joining us today. As mentioned earlier, for those who have just joined us, my name is Andrew Zaffel, and I'm a manager for health equity here at NASTAD. And thank you for joining our webinar today on ensuring gay, bisexual, and other men who have sex with men are engaged in ending the HIV epidemic planning, a part of our overall work around National Gay Men's HIV and AIDS Awareness Day. Thank you again so much for joining us. Next slide. So today we're going to be talking about quite a few different topics. First and foremost, I'll present a little bit on some of NASTAD's works on gay men's health equity and transition it over to our speakers, who will be presenting a broad range of different topics and how they've worked with this population in their ending the epidemic planning as well as programming. We'll then have some time for questions and answer as well. Just in terms of a bit of housekeeping, before we do get started, I do ask that you please mute your computer microphone or telephone during the presentations, and you can feel free to use the chat feature to ask questions. We'll address these during the Q&A periods. For those who are using this through their computer, you can find the questions as part of the tab with GoToWebinar. For those who are calling in, we're also happy to unmute you as well to be able to answer questions. If you would like to also voice your questions, please feel free to click the raise hand button. We will open up the chat feature during the Q&A periods. Just note this webinar is being recorded and will be made available as well as the slides at a later date via our website at nastad.org. And as always, if you'd like to have any more information or discuss any of these topics further, please feel free to contact me, Andrew Zaffel, at azaffel, Z-A-P-F-E-L, at nastad.org. So as I mentioned, we're going to start briefly on some of NASTAD's work on gay men's health equity, and specifically looking at the work group that NASTAD has developed. The NASTAD Gay Men's Health Equity Work Group is focused on providing a space for health department staff to openly discuss structural barriers to full access of care for gay, bisexual, and other men who have sex with men, or GBM as NASTAD is using. We engage diverse stakeholders in the development and dissemination of products to support the holistic care of GBM and ensure the voices of the most marginalized are centered in the discussions around GBM healthcare and ensure our work remains transparent, accountable to those we serve, and adaptable to diverse communities. The Gay Men's Health Equity Work Group is made up of health department staff across the United States and meets regularly to work on these following goals and discuss these kind of topics. If you are interested in joining this work group or having further conversations on gay men's health equity, please feel free to reach out to me and we'll add you to our list for our monthly as well as quarterly conversations. Now, to dive into a bit of our work, NASTAD's focused over the past, in 2019, has been focused on these 4 key areas: community engagement, CBO sustainability, community-based organization sustainability, mental health and drug use, and reducing stigma. With community engagement, NASTAD has recently released the 2019 GMHE Community Engagement Survey, where health departments have provided us a plethora of different responses on how they plan for, implement, and monitor their community engagement activities with their programs around HIV and viral hepatitis. And we look forward to analyzing and disseminating data this fall over the next few months. Besides community engagement, we also focus on community-based organization sustainability, particularly those focused on gay, bisexual, and other men who have sex with men, or as well the broader LGBTQ population. We've also discussed ways of supporting more grassroots effort through microgrant funding and capacity building support to growing or new community-based organizations as a group. And we've also included a number of questions on how health departments can support the capacity building as well as sustainability of community-based organizations in the community engagement survey. And again, we look forward to disseminating those findings over the next few months. The work group has had a number of different conversations focusing on trauma-informed approaches, especially to this population, as well as looking at different areas around drug use and harm reduction approaches that can be taken that reflect the needs of gay, bisexual, and other men who have sex with men. And finally, we also are always working to reduce stigma. We've recently released an issue brief on health department GBM website presence, looking at how health departments are providing holistic care and prevention and care information for this population, and supporting and developing online materials to disseminate this health information as well. We have links to those websites as well, and happy to share them if you'd like to email me, and we'll share them as well when we disseminate the webinar recording as well as the slides. NASTAD is also working among many different areas to support conversations, look at specific projects and activities, or as well as ensure culturally responsive care to this population. We have a number of tools, briefs, and resources, and are more available to help continue these conversations after this webinar and to continue this work. And feel free to visit our website at nastad.org for links to all of these different tools that we have available to help you in your response. I want to switch now the conversation over to the webinar today, specifically looking at the Ending the HIV Epidemic, a Plan for America. With the goal of 75% reduction in new HIV infections in 5 years and at least 90% reduction in 10 years, NASTAD is committed to helping health departments in ending the HIV epidemic. A number of jurisdictions have already developed, are currently developing, or are about to begin intense work on the development and implementation of their Ending the HIV Epidemic plans. And as we know, community engagement is critical. And given the disproportionate effect the HIV epidemic has on gay, bisexual, and other men who have sex with men, it is critical that we engage and welcome the inputs of this population into our work. And we know that in order to reach our local, state, and the national goals as presented on this slide, this population needs to be centered and prioritized in all the work that we do. We won't achieve any of these goals without reducing the transmission of HIV and meeting holistic needs of this population. And with that, now I'm going to switch it over to our speakers to share a bit more about their programs and their work that they've done to really engage this population. The following health departments, community-based organizations are working to ensure this full engagement throughout their Ending the Epidemic plans. And with that, I'm going to hand it over now to Jessie Carter, who is the lead planner of the HIV/STD Prevention and Care Branch of the Texas Department of State Health Services. Jessie, I'll let you talk now, and thank you so much.
Great, thanks, Andrew, and thanks for inviting us to be part of the call. We're excited to be here. I hope everyone's having a great Friday and excited for the weekend. So I want to just give some background and philosophically in Texas on how we approach inclusion and trying to get community voice. And also just as structurally, we are at the health department, we're incredibly decentralized, so we don't do direct client services, so that's a struggle for us in interacting with directly with community. And also we, in planning, we like to keep in mind the size of the population to give ourselves perspective. We estimate that there's between 500 to 600,000 gay men in Texas, and that's certainly, gay men make up over half of the people living with HIV in Texas, and we estimate that a gay man's diagnosed every 3 hours in Texas. So we use those to create some urgency and some perspective for ourselves and our colleagues and the folks that we interact with. One of our primary ways of engaging community is, I think, a pretty typical old school planning method, which is our integrated prevention and care, statewide prevention and care planning body. Here in Texas, we call it, it's called the Texas HIV Syndicate. It's a pretty large body. It's made up of 114 members, active members currently right now. And our membership is primarily leaders of organizations and program leaders across the state. And one of the challenges we face, and I imagine it's like this in many jurisdictions, is a large portion of our workforce doesn't represent the communities that we serve. So that is a challenge when we look at our membership and we're recruiting from our organizations and from community, but from our organizations to participate, we have to be conscious of that. And so we try and recruit, specifically try and recruit folks for parity, inclusion, and representation, and try and include voices from community on that. The body is run by an 18-member co-chair body who represent across the state, and they review applications, and they're always mindful of the makeup. So right now on our community planning body, out of that 114, about a third of the body identifies as gay or bisexual men, which is pretty good given the makeup of our workforce and where we're going, but we're always conscious of wanting to do better. And we are exploring ways to explode that out a little more and open it up and try and do more community recruitment to be members and participants of that. But in developing our ending the epidemic plan, the core body was the Texas HIV Syndicate, but then we also looked at community partners and recruited more people to the table to try and bring in more voice in developing our plan over the year that we did develop it. And out of that, as we've rolled forward into implementing our plan, and through our syndicate body, we've created what we call our population affinity groups for our 5 priority populations in the state of Texas, which are Latinx gay men, Black gay men, white gay men, transgender women, and Black women. And those groups we have statewide calls once a month to look at issues in the community and how we can improve prevention and care services and practices for those communities. And we're actively and constantly trying to recruit more community voice on those. To some extent, like some work better than others. We have a pretty active Latinx gay men's group. It's pretty large, and there's a lot of community voice in that. The Black gay men's group and the white gay men's group is a little bit more of a challenge to bring those in, but it's a work in progress, and we're looking at ways to expand that all the time, and then moving into the new year, ways to grow that as well. Like I said, we're decentralized, so some of our struggles, we usually are our method of working with community is through our providers to try and do recruitment. And so we are also investigating ways that we can have more direct and engaging communication and involvement from our level with communities across Texas. One of the challenges of that, of course, is in Texas, the size of Texas makes it difficult for us to get out and talk to people around the state. Some of the things that we're doing and we've lessons learned from those affinity groups are how we advertise and get word out, how we engage the population, certainly what we've learned, and a couple of them is even just the time of the call. It's sort of reflexive to have have calls and engagements for most of us, and I think this is pretty basic for some of us, but to do that during our business hours because that's when we're working, and certainly a couple of the calls, what we've heard from people is it doesn't work for them. So we've started doing after hours calls to try and get more community involvement, and that's been really beneficial as well. Some of that, one of the other things that has come about through that, and one of the experiments that we've done in terms of community engagement is we've been really focused on engagement with the transgender community, and some of the lessons learned from that will be being brought into some of the other affinity groups. So with the transgender affinity group and some other projects that we've done, we've recruited a steering group of trans identified folks from around the state to serve on a steering group, and we're providing them with a stipend to serve as advisors to us, to run ideas by, but also to be that conduit to the community, to help us reach out and bring more people into the conversation. And we're looking towards using that model into the new year, in terms of identifying some ambassadors and some influencers across the rest of these population groups that we can bring to the table and give them a stipend to serve as in an advisory capacity, for us reaching out into the communities across Texas. And then one of the other things that we're doing that I'm super excited about here in Texas, we're starting it this year and it'll run through next year. We're piloting what we're calling the Texas Health Equity Fellowship. This is focused on, out of our ongoing health equity work that we've been doing over a number of years. This is developed, and this fellowship will be focused on young Latinx and Black gay men and young trans women of color. And we're developing a year-long fellowship program to do leadership and skills build training, in order to increase the number of folks from community who are serving in meaningful ways out in our organizations around the state. So we are right now at the point of developing that curriculum. We have contacted providers across the state to find out what sort of skills they're looking for in terms of people coming into their organizations, so that we can make sure that we're addressing that. We've had some calls with some young Black and Latinx gay men from around the state who might be interested, to explore the idea with them. So we're launching that next month through an application process to bring that on, and we are looking to develop 5 teams, regional teams of folks out in the communities around Texas, who will be engaged in this fellowship over the course of the next year, and then we'll also be working on community projects within their own regions. And part of that fellowship is also their involvement and engagement in our planning processes. So they will also be brought in as part of that, to the Texas HIV Syndicate, and will serve a role within the syndicate, in a way to also bring their voices into the group, but also as a networking opportunity for them to meet a lot of the leaders and people around the state. And that's the basic recap of a lot of our work here in Texas. So I know when we get to the question and answer session, if anyone has any questions about any of those projects, I'll be happy to answer them.
Great, thank you so much, Jesse. We do have a bit of time now, so if anyone does have any questions, we could take a minute or two to answer them. Feel free, if you'd like, to use the question feature as part of GoToWebinar, as well as if you'd like to instead raise your hand, feel free to click that button as well. We can take a minute or two now to see if there are any questions. Here we go. Oh, great, we already have a question here. Let me open up one moment. So Jesse, in Delaware, we are challenged reaching Black gay men who unfortunately are disproportionately represented in annual new infections. Do you have any suggestions based on your work in reaching out to this population? We might save that question as well for other speakers as well. So Jesse, don't feel like you're the only one meant to answer this question.
Okay. I think, again, I think learning from what a lot of our colleagues at CBOs and folks around the field, the state have already been doing is, and as I said, one of the strategies we've been doing is trying to identify influencers out in the community. It's a very classic sort of popular opinion leader method, but trying to find folks out in the community who are influencers and having one-on-one discussions and engagement with them, and then working through them as gatekeepers to their community to try and bring on more voices. We've had some success, and honestly, some of the lessons that we're learning through those affinity groups, across all of the gay men's affinity groups, and the feedback that we're getting from community is that folks out in true community aren't super interested in singular focused conversations around HIV. And so we've also been trying to expand our conversations and the topics that we're putting out in order to bring more people and more voice to the table by not focusing so much on just HIV messages and bringing people to the table to tell us, how do you improve HIV testing for Black gay men, but having broader conversations about what does whole health look like for Black gay men, what would a whole healthcare provider look like, what are the other service needs. We are having a lot of conversation across all of our groups about the growing interest in status neutral systems, and again, making the center of the conversation not about HIV, but the needs of the community and HIV is just one of those. And so right now we're engaged in a lot, I think, of really interesting and exciting conversations about what those services and what a whole healthcare, a whole needs-based system that's addressing the needs of individuals and community in these communities looks like, that isn't HIV centric, but HIV is included in that. And that, I think, has helped bring more people out in the field into some of the conversations, because that is where they're at and that's what they want to talk about. And then I think it's our job then to mine that for what pieces of HIV information directly impact our work, but also like how do we start shifting our systems and working with colleagues to create those whole health systems for those communities. But I know that that's one of the strategies that we've found, is that shifting the conversation so it's not HIV centric and really trying to respond to and understand what the community wants to talk about, and then framing it around that to bring people into the conversation.
Great, thank you so much for that. I'm just going to ask one more question because it came up from a few people, and then we'll move on to our next speaker. But could you talk a bit more about how you recruited or interviewed and provided stipends to the advisors, particularly the transgender advisors you mentioned as part of the working groups, especially in this all within a state government system, and particularly the questions around stipends, how you're doing that?
Yeah, we're fortunate. Part of for all of the planning activities that we do here on staff within the health department, there's really myself. When I say I'm the lead planner, there's myself and one other planner. But we have a contractual relationship with the University of Texas that provides technical assistance and innovation and supports planning processes for us, which provides a larger team for us to work with, because the amount of activity that we do would only be made possible through that. But it also has created some flexibility for us in order to do stipends. And I firmly believe, and again, in I think talking to community, some of the lessons I've learned in the years of doing this is particularly gay men of color and those communities, there is a tremendous and I think well-justified sense of exploitation. We as agencies and our providers go into the communities and do assessment work in order to write for grant applications, and then hold that money, and the community rarely has access to it, and the information is guarded. So trying also to give information back. So that's where the idea of like paying people for their time and their expertise and honoring that comes from. So this last year was sort of a pilot for doing that with the transgender group. And the way we worked with it is we had some really well-known, a few really well-known transgender women who were serving on the Texas HIV Syndicate. We worked with them to talk to them about how this would look, and also get recommendations from them about community members around the state who they felt would serve on the group, who were outspoken, who could participate, who knew their communities well. So that the contacts that we already had allowed us to make further contacts and reach out to those people and ask them and invite them in and have some conversation with them. And then again, our ability to, and I mean, it's not a huge stipend, but our ability to actually pay them for their time and for their expertise, I think has been really beneficial as well. And we've been able to do that again through our contractual relationship with our partners at the University of Texas.
Great. Thank you so much, Jesse. We're going to move on now. Please continue to type in your questions. We definitely have time during other speakers as well as at the end to answer any additional questions you have. And if we don't get to your question, we'll definitely try to follow up as well to make sure that we get your questions answered. But thank you all so much. And thank you again, Jesse Carter, for that presentation. Our next speaker is Barry Callis. Barry Callis is the Director of Behavioral Health and Infectious Disease Prevention as part of the Bureau of Infectious Disease and Laboratory Sciences for the Office of HIV/AIDS at the Massachusetts Department of Public Health. Barry, I will turn it over to you.
Hi, thanks so much, Andrew. Good afternoon, and in some cases, good morning, everyone. My name is Barry. I work for the Office of HIV and AIDS, and we're a division of the Bureau of Infectious Disease and Laboratory Sciences at the Massachusetts Department of Public Health. And I was asked to highlight some recent work that we've done focusing on completely redesigning our statewide community engagement and advisory system, specifically addressing engagement of gay men in the HIV response. And for us in Massachusetts, Suffolk County is one of the counties that has been identified in the Ending the HIV Epidemic initiative that was announced in early February. And so that's actually offering an accelerated platform to address and respond to the needs of gay men. What I'm going to be talking about, I just have a few slides, but what I'm going to be talking about after this first title slide is giving you all an overview of some work that we did before the EHE initiative was launched and subsequent to that time on what we've been doing to completely overhaul the work that we do around community engagement. And that's just to say that we are doing this work in real time. Next slide. Next, I wanted to give a little bit of background and context for community engagement and advisory in Massachusetts. And some of the things that I think are important, at least that I've learned so far, that are important to be successful. And we're lucky enough to have a whole, in our office, we're about an office of give or take between interns and staff, 18 to 21 people. And so that's not a lot for an entire state. And designating attention and an explicit role for people to pay attention and to do community engagement and advisory is really key. If you're not able in your health department to do that, if you can find some partners, whether they be community partners or academic partners to do so, I would recommend that. But we're lucky enough to have a small team, myself and two other individuals primarily, who are doing this work, and others in our office who are providing content expertise. In Massachusetts, we have a long, I think, pretty proud history of engaging consumers, people living with HIV and those that are at risk for HIV over a number of years through a number of different forums. So we're really proud to have a long-standing positive relationship with organizations that we work with and the community overall. In 3.5 years ago, we integrated our prevention and care system, or both the service system and the advisory system, and we have an integrated prevention and care committee. And that committee did some phenomenal work with us that included the development of our integrated prevention and care plan that we submitted. But that group really was a great forum to help inform what we're currently doing around advisory and engagement. Their membership was coming to a close, and throughout the 3-year period of time, but more importantly, during the intense time of developing the integrated prevention and care plan, we began to hear very loud and clear the ways in which we could do better, the ways in which we could hear from more voices, more diverse voices to assist us in our response. So our advisors were really telling us that we needed to have greater depth and specificity of our response. And by that I mean folks are really telling us to be racially and sexuality explicit in how we go about doing our advisory. And we heard that loud and clear. We did some assessment with other cities and states throughout the country and looked at what they were doing around community engagement advisory to help inform what we thought would work locally here. So what that, next slide please, what that resulted in was the development of a new community engagement and advisory system, and by that I mean we created a new application for individuals to apply to us to be part of one of 7 groups. So we were recruiting for 7 groups in our state. Those groups included our Integrated Prevention and Care Committee, our statewide consumer advisory group, a Black advisory group, a Latinx advisory group, a transgender health advisory group, and a subject matter expert group, our behavioral health group. And in many ways, we piloted what we thought we were going to have for the last year with a trans health advisory group, which was really instructive for us. It allowed us to see what size of a group we needed, what kind of representation we needed, what kind of content could we bring to that group, and what could we generate to improve the response. So our trans health advisory group really was a great example of what we, it really helped us inform what we were going to do in the future. So we released our application in June of this year to over 1,300 people in Massachusetts, and that included individuals who work in the programs that we fund. We have integrated prevention and care programs for HIV, hepatitis, and STDs. We are aware of a number of different organizations, faith communities, individuals who work in corrections, substance abuse, LGBTQ health, elder health. So we distributed this pretty widely, and we got a phenomenal response. One thing that we were really attentive to is that we wanted the application to be accessible. We wanted folks to understand what they were getting into, but we also wanted it to not be overly cumbersome for them to respond. The application itself described each one of the advisory groups, the frequency with which those groups were going to meet, and what their particular role was going to be as a member. Irregardless of what advisory group you were applying for, we had a standard set of expectations, what they could expect from us as health department staff, what we were expecting from them, and what they could benefit from in terms of being part of that group. So we recognize that there's mutual, we wanted to be clear that we thought that there was mutual benefit. The other piece of this system is, we are very aware of the ways in which we can help facilitate individuals' growth and development and leadership. And so we see participation on one of our advisory groups as a pathway to greater involvement and leadership in the future. A few principles that guided how we reviewed our applications. We wanted to be sure that there was representation by impacted populations. We wanted to be sure that each one of our health service regions, so Massachusetts is broken up into 6 health service regions. We want to be sure there was representation. We wanted to be sure that technical advisors, providers of prevention and care, allied partners, and others were both received the opportunity and applied. We didn't just leave it to the dissemination of an email encouraging people to apply. We definitely saw that as a way to blanket access, but we used ourselves, we used the networks, and we used those that we know to get the word out. At every single meeting we attended in the community, we talked this up, whether it was infectious disease related or not. We relied on those that were part of our existing system to talk this up as well. So we received an overwhelming response to this solicitation. We also talked this up quite a bit over the last few months before we released it, just so that folks could be aware when it arrived in the inbox and can talk it up among their peers. Next slide, please. So what did this result in? And I want to focus a little bit specifically on gay men as it relates to a gay men's advisory group that we've seated. We have 18 people, 90% of which are gay men, seated on a gay men's health advisory group. But we explicitly have seated gay men on 5 other advisory groups to be sure that there's representation there. We recognize both the value of working through a provider system. This is a medical and non-medical provider system that we fund. We recognize the value of that, and we also recognize the limitations of that. And we've come up with the idea that our advisory groups certainly are engaging people that are working in the field, folks that are working in corrections, substance use, LGBTQ health, elder health, in other fields. So we recognize the value of that. But what we've come up with is that we want each one of our advisory groups, through the networks that members have, we want to host local convenings of individuals who won't come to meetings for whatever reason, whether it be inability to travel or not seeing it as something that they want to participate in. So we're really looking forward to members of our advisory groups, along with us, co-facilitating local advisory activities, local engagements, local town halls, living room chats, coffee hour chats, to talk with gay men about their health, to talk with gay men about stigma, about PrEP, about how to promote access to all the services that we fund in potentially new and different ways. So we want to expand the reach of our advisory activities beyond providers and use their networks that they have in their local communities to have local convenings. The other thing that we've done as a jurisdiction that's identified in the ending the HIV epidemic initiative is that we have formed a new EHE steering committee. And that steering committee, while focusing on Suffolk County, which includes Boston, Revere, Chelsea, and Winthrop, those are communities just slightly north of Boston. We are being very mindful to be representative, to have representative people at risk and living with HIV gay men on that steering committee in large numbers, in large force. The other activity that we're engaged in right now, we're lucky enough as a region to be close to other states. There is a revival of our New England Alliance for Gay and Bisexual Men's Health, and we're coordinating with that initiative to share themes, to share tools, to share ideas, and to gain others as well. So I also want to close by acknowledging that we don't have the magic or secret sauce to make this successful, but we think that we've built this very differently from what we've had in the past. We have a lot of new opportunities to reach gay men and those that serve them. We're very excited by what we're doing, and we think it will have a different kind of impact on the service system that we fund, which is what this is all about. I do want to acknowledge our office director, Don Fukuda, who has really helped support the team that does this work in our office, including Emily Levine, Eduardo Nettle, Dennis Canty, Linda Goldman, and Annette Rockwell. And I would be remiss without mentioning Email Day as well. So I'm happy to take questions about what we've planned and what we're rolling out in real time, either now or later on.
Great. Thank you so much, Barry, for that great presentation. There's 2 questions for you, and then we'll move on to our next speaker. The first question, I'll just read off both of them for you. Was the recruitment for these consumer groups solely a Massachusetts Department of Public Health effort, or did you work with community organizations? And the other question is, are you providing stipends for any or all of the members of these different advisory groups? And if so, how do you manage that?
Okay. Andrew, I may ask you to help me with the second question just to be sure I hit all the points, but they're excellent questions. So as far as recruitment, we relied, we're lucky enough to have a electronic learning system for staff that work in our funded organizations. And we had over 800 names just in that database alone. So we relied on that system. We relied on our relationships with other planning bodies and other stakeholder groups to get the word out. So this was not us alone, but we asked the help of others to get the word out.
Great, thank you.
In terms of question number 2, the question has to do with stipends and how did we message that?
Oh, manage that.
How do we manage that? Okay, so I actually want to, I think messaging and managing are 2 important things. So for individuals who are living with HIV that are not employed or who are underemployed are eligible for a stipend to attend meetings, and that includes mileage or transportation reimbursement and child care reimbursement. So we do stipend individuals for that. We message that in our advisory application, we describe eligibility. We have a logistics vendor that assists us in reimbursement for that, as well as helping us secure and pay for space, food, and other logistics needs.
Great, thank you so much. And again,
hopefully I hit on all the points of that really good question.
Thank you. No, I think we did. I think we'll continue this conversation after our last speaker as well. I just want to make sure we give them that time, and definitely thank you again, Barry, for that great presentation. And last but certainly not least, we're going to hear from Arizona. Specifically, we're going to hear from Michael Lopez, who is the Associate Director of LGBTQ Prevention Services with the Southern Arizona AIDS Foundation. We'll also hear from Deborah Reardon Maynard, who is the Program Improvement Management at the Office of HIV Prevention with the Arizona Department of Health Services. I'm going to turn it over to you 2 now to present on our final topic today. Thank you.
Good afternoon. This is Deborah. I'm going to start with our health department response, and then I will turn it over to Michael to really talk more about the project. And we were asked to discuss a project that we're working on for community engagement and creating an action plan for Hispanic and Latino MSM or GBM, and trans Latinos. So the health department started with the prevention conference back in April, I think, March or April, where the office chief for our HIV prevention office, John Sapiro, which the NASTAD folks are really familiar with, had attended the Hispanic and Latino MSM workshop and came back from that with the beginnings of an action plan really focusing on the community engagement that we felt that we needed to improve and really have more engagement with that population here in Arizona. So he came back, got me involved with it, but we looked at it and we understand that we are probably not the best people to lead this kind of community effort. We're the health department, we're middle-aged white people, and what we really wanted were folks that represent the community and can do this work in the community in a very meaningful way. And so we invited some of our partners to create a steering committee, and then we asked Michael Lopez from Southern Arizona AIDS Foundation to lead this and to really be the lead of this whole project. But what the health department got involved with at that point was we had this goal to have something meaningful, to have a plan with the community that we can move forward and not have it just be a rehash of let's do a needs assessment and then have it sit on the shelf. We want this to be something that we can move forward with and have actions with. So we looked at it and said, from the health department, we can make sure that what we're doing here aligns with the other plans that we have in place. So our jurisdictional plan, Phoenix is a fast track city, and Tucson is becoming a fast track city. The Ending the Epidemic plan, and then to also coordinate with the various planning groups around the state to make sure that what we're doing all works together and that we're not working against ourselves. So we did that, and then we set up support for this, because kind of one of our big concerns was that we not look at it and say, here, go do this, without having the support set up. If we want to do a needs assessment, or the group says we need some analysis of data, we wanted to provide for that. So we worked with one of our vendors, our contractors that we have in place that does that work, and we can support that. Having the financial backing to be able to say, yes, people can travel to come to these meetings. We can set up focus groups. Any of those contractual needs and compensation for Southern Arizona AIDS Foundation for taking away Michael's time and being able to build that into the work that they do with us. And so I think that's basically where the health department is really focusing there, is just to say we want to have a commitment to this and be very supportive of this work moving forward. And so I'm going to turn this over to Michael and let him talk about the really good, important information.
Thank you, Deborah. Hi, everyone. Good morning. Good afternoon for folks. Again, my name is Michael Lopez. I am the Associate Director of LGBTQ Prevention Services with the Southern Arizona AIDS Foundation, located in Tucson, Arizona. I wanted to talk about more specifically about this HIV Latinx steering committee that we are working on to kind of create a draft plan, a plan to really get the state moving forward in helping reduce the HIV-related health outcomes for specifically Latinx men who have sex with men and the trans Latinx individuals in our communities. Our goal is to try to determine the best means of this kind of community engagement and what it looks to implement these particular action items and goals for this particular thing. Currently, we have 19 individuals on this steering committee, including myself, comprised of community partners, representation from our state health department, several community-based organizations in both Tucson and in Phoenix that work specifically in providing HIV services, but also specifically these individuals who are working closely and directly with the Latinx population in these two areas, as well as our local clinics in these two areas. One thing to note that as we've just recently started this steering committee back in August, which we really started laying the foundation and the groundwork for this particular plan, we currently do not have representation specifically from the community at this table. But again, the purpose for the community partners that are involved in this steering committee having direct relationships with the Latinx population also gives voice to that population, but we do understand that we are not specifically part of that community. We might represent, be part of that community, identify as that community, but our voice is really coming from, at a different power in that relationship with the services that we actually provide as organizations and to the people that are needing the services that we have. So I really wanted to make that as a clear point, because that is a conversation that comes up within our steering committee as we're kind of moving forward with that one. In addition to this particular steering committee, we also work closely with our Arizona's HIV statewide advisory group, which we call SWAG here in Arizona, which is a volunteer organization that is supported by our Department of Health Services, which again looks at how HIV impacts populations across the state, the factors that are influencing people's HIV risk and the structures that impact successful HIV efforts. And then SWAG's task is to be that liaison with the community and the State Department, and then recommends those successful, ideas and strategies around prevention, care, and treatment. So the work that we are doing in our Latinx steering committee, and with this particular plan, again, our goal in the statewide is to have influence amongst all of these plans that Deborah was speaking to, with our Ending Our HIV Epidemic plan, our statewide jurisdictional plan, as well as our fast track city plans, and really making sure that there is a lot of communication amongst all those, and the work that we're doing is not separate, but as it can be comprehensive and inclusive in all of those target areas, which has been exciting for that. So again, we've started this steering committee to begin our initial conversations and what we kind of want to have envisioned in like the work that we wanted to do. Understanding that there has been assessments done in the past around this particular population, one specifically with a local CBO in the Phoenix area around this population and HIV related topics, as well as a campaign research assessment within this population to understand their relationship between what impacts them with HIV, their knowledge around this particular area, what hurdles they may face, emotions, stigma, shame, cultural influence that may impact someone for accessing services that are playing a part in HIV-related incidents. So we really were trying to assess what has already been done, as well as now thinking largely and broadening our own concepts of how do we approach this particular plan with this particular population. And a lot of conversation is really, moving from, engaging in our community around being, HIV-centric conversations, but more in general health, because we understand that our population, the Latinx communities, are not really concerned about HIV because they're really more concerned about other topics around their health, including high blood pressure, diabetes. But a lot of these are informed by their cultural responses and their cultural upbringing around stigma, around shame, around the concept of the machismo, culture with men who are having sex with men. So these are areas that we wanted to making sure that we have a strong understanding in the way that we want to implore and move forward with our plan. A strong conversation also came up in the response to how do we really make impactful change when we need to move the system from from an up to down concept where it's mandated by the federal components to the state components, moving down to CBOs and then to the community, but really envisioning a plan that actually works from the bottom up to actually hopefully create change within those upper levels that we know that sometimes are barriers when we're trying to engage in our community or get access to services with those particular people. Other areas that we focus on that we're really trying to think about is what does that community engagement really consist of? We know before certain town halls, focus groups, assessments really only limit a certain subpopulation within our whole community as a whole, when our goal is to really tackle this from a larger level community and not those specifically directly impacted by HIV, but understanding that we do have to think about it in a cultural shift. So really moving into areas that the state or local CBOs or local jurisdictions are not tapping into. So within the work that we're doing, we really wanted to try to now think outside that box and start targeting specific grassroots organizations that maybe are not at the table, bringing them to the table. And we are now currently strategizing in ways to recruit those particular efforts. October is fast approaching, and we have two big events that are in our local areas. In the Phoenix area, they are having their second annual Latin Pride event, which our goal is to recruit, have conversations, to bring people to the table to really help with this particular plan. And as well as in the Tucson area, we have the National Latino HIV/AIDS Awareness Day, and we actually have a planning committee that's been in place for the last, I want to say, up to 10 years, which is, again, local community partners doing volunteer work to have a planning committee to create an event around the October 15th National Latino HIV Awareness Day that brings community and conversation around this topic. So again, we're trying to leverage these particular events to begin the conversations in that community engagement and hopefully recruit more people to our steering committee, or again, as part of our plan, to really develop other focus groups and steering committees that can really be led by that community more specifically, so then we are able to leverage off of their voices, bringing them to the table. I think some things that we haven't done really mindfully in the past, but we're really, our goal for this particular plan is really looking at this plan much more largely with that. You know, we also are feeling that we need to include conversations around sex work, including that particular language in our plans, you know, which we would recommend for any jurisdiction to really include, you know, immigration, deportation, access to, you know, citizenship. These are the things that we know that are limiting our population into getting services. There still is a fear trying to access, you know, healthcare clinics, especially those that are undocumented, feeling that they may be, you know, deported, or their information may be gathered to be used in other means that may, you know, directly affect the way that they are trying to access care. Also, a lot of the work that we are currently doing is, again, around all of these particular points. And again, our moving forward is to really start to recruiting, and I think that's where we are in those phases. But I think the conversations have been very impactful and informative in the way that we're trying to engage these communities that will lend to a plan that we can definitely implement, definitely for 2020 with that. And that's all I have currently, because again, we are still in our initial phases with this particular plan, but I'm definitely open to up for conversation or questions regarding some of that work that I may have missed.
Great. Thank you both so much for all of that information. Thank you so much. I know that we are coming up towards the end of the hour, actually, about 3 more minutes, but I will want to just give people some time to see if they have any questions, and feel free to add them to the question box. Because even if we might not be able to get to it at this time, we will definitely follow up with any specific questions you may have. And just to note that this webinar has been recorded, and we will be sharing out the webinar as well as the slides to everyone, and as well as contact information should you have any additional questions. I do like to add on a note, we did get one question during it, more of a statement actually for you, Barry. I used to be a member of the statewide community advisory board in the 90s, and you had a great system back then, and just note of great job. So I just wanted to add a little nice note towards the end of the hour, Barry, on the great work Massachusetts has done throughout the years.
Great. Thanks for that comment.
And there's a question here about providing contact information for the presenters. Yes, we'll reach out. My next slide will have my contact information, and happy to network anyone who would like to discuss anything further. All right. Well, with that, I just want to give one final big thank you to all of our presenters today who really shared such great information about the ways that they engage community members in their programs, as well as really thinking through ending the HIV epidemic. And I think we're going to continue to have these conversations as we move forward, how best to meet the needs of the community, as well as make sure they are part of all the conversations. I'll just finish off with my last slide again as a thank you, not to all your presenters, but also to those who attended today. Thank you so much for taking the time to be a part of this conversation. And as always, if you ever want to need more information, would like to talk more about these things, or network with others who are working on this topic, please feel free to reach out to me. My email is located on the screen, as well as I can I will be sending out an email afterwards to all of those who participated or registered for the webinar with more information. With that, I just want to thank you all so much for taking the time to be with us today, and we look forward to chatting next time. Wishing you all a great rest of your day, and I wish you all a great weekend. Thank you so much for your time.